Nair Firdaus to take over and do the Qiraat, please.
Bismillahirrahmanirrahim. Yeah. Bismillahirrahmanirrahim. قل ادعوا الله وادعوا الرحمن يا من ما تدعوا فله الأسماء الحسنى ولا تجهر بصلاتك ولا تخافت بها وابتغ بين ذلك سبيلا وقل الحمد لله الذي لم يتخذ ولدا ولم يكن له شريك في الملك ولم يكن له ولي من الذل وكبره تكبيرا. Say, O Muhammad sallallahu alayhi wasallam, invoke Allah or invoke the most gracious Allah by whatever name you invoke him, it is the same. For to him belong the best names, and offer your salah neither aloud nor in low voice, but follow away in between. And say, all the praises and thanks be to Allah, who has not begotten a son nor offspring, and who has no partner in his dominion, nor he is low to who have a wali, helper, protector, or supporter. And magnify him with all magnificence. Allahu Akbar, Allah is the most great. Chapter number 17, Surah Al-Isra, verse number 110 to 111. Ali, back to you.
Thank you, Dr. Firdaus. Nida, we all set to go. Please, I'm going to mute everyone and we'll just allow the speaker to talk. Thank you very much. Good luck.
Assalamu alaikum, everyone. Myself, Dr. Nida Ahmed, oral and maxillofacial surgeon. Today's topic for webinar is efficacy of dexamethasone in third molar surgery. Today, the contents for today's webinar is introduction. I'll briefly be talking about impaction, the third molar surgery, and I'll be talking about the sequelae of third molar surgery. And I'll just be giving a brief talk about the inflammation so that we can understand the mechanism of action of dexamethasone better. Then I will just be throwing a little light on the sequelae of third molar surgery, that is the swelling, trismus, and pain. So these are the three main sequelae of third molar surgery today, which we'll be dealing with. Then I'll be talking a little about corticosteroids, a basic classification and all that. And then I'll be talking about why dexamethasone is the most preferred steroid as compared to others. And what we're going to do in this webinar is I'm going to put up 4 questions in the starting of the webinar. And hopefully by the end of this webinar, we'll be able to answer these 4 questions. So those 4 questions are, the first one is the timing of the steroid. That is the timing of the dexamethasone, which we're going to give. That is either pre or post, okay? So we are basically going to compare the pros and cons of a preoperative and post-operative injection of dexamethasone. So by the end of this webinar, hopefully we'll arrive at a conclusion that which is better, a pre or a post-op. The next question being effective dose. Okay, there are many doses. The different articles have come across. Few have compared with 4 mg, 8 mg, 10 mg, and 12 mg. But I'm just going to compare 4 and 8 mg. So by the end, we will decide which is a better dose or which is a more effective or a subtherapeutic dose of dexamethasone. The third question being whether a systemic or a local route. Okay, I think most of us have been giving dexamethasone as an IV or an IM, most of them. So today we will see if local administration of dexamethasone is better than systemic. If yes, why or not. We're going to debate about systemic versus local routes of dexamethasone, and we're going to see which is better. The last one, once we arrive at a conclusion, systemic or local, which is a better, we're going to see which is the most favored route among the systemic and local. Okay, so these are my 4 basic questions which I've put up in the starting, and hopefully by the end of this webinar, we're going to arrive at answers to this, and we'll see how we go about it. Okay, so to start off with, introduction. The surgical extraction of impacted third molar is the most frequent minor surgical intervention which we see in oral surgery. Okay, but this invasive procedure elicits an inflammatory response which mainly manifests as 3 major complications which I told in the starting, that is pain, swelling, and trismus. Okay, so because of these basically 3 complications which occur, we have seen the most amount of reluctance in patient to get the third molar surgery, because most of the patients which come, they've already, Googled, they've already seen what are the complications which take place. They already know what's going to happen. Okay, so they're more or less aware of the pain which will persist, the swelling and the limited mouth opening and all that. Okay, so basically we need to target these post-operative complications so that we can make it, as the definition of exodontia says, we should try making the procedure as pain-free as possible for the patient. Okay, so whatever today we're going to be talking about, basically I'm going to focus the mechanism of action of dexamethasone on these three sequelae of third molar extraction, that is swelling, pain and trismus. Various drugs have been considered to reduce these post-operative inflammatory response. Okay, time and again, NSAIDs, the corticosteroids, many drugs have been used to combat or to deal with these post-op complications. But why corticosteroids have an advantage, or why do they have the maximum anti-inflammatory effect? We'll be seeing that throughout. To start off with, I'm just going to give a brief insight into the inflammatory pathway, so that when I'm talking about corticosteroids, we'll exactly know where the corticosteroids act or how do they have their anti-inflammatory effect. So coming to the first one, whenever there is a tissue injury, okay, whenever there is a tissue injury, the membrane phospholipids which are present gets converted into arachidonic acid by the enzyme phospholipase A2. Once the arachidonic acid is being converted, the arachidonic acid starts the inflammatory response, and it follows two pathways. First being the cyclooxygenase pathway and the lipoxygenase pathway. And the end products of these pathways are prostaglandins, okay, from the COX pathway, and leukotrienes from the lipoxygenase pathway. So these prostaglandins play an important role in inflammation, pain, and also increase in body temperature. Whereas your leukotrienes classically play an important role in your inflammation. Now, once these the inflammatory pathway is started, there are a number of cells which come into picture. Those are your mast cells, your neutrophils, your macrophages, your eosinophils, your monocytes. All these cells are exudated, or they all migrate towards the site of injury in order to deal with the noxious stimuli or to deal with the tissue injury which has occurred there. Along with these, there are a number of inflammatory mediators which are released so that they can act upon on the tissue injury which has occurred there. So those inflammatory mediators are namely histamine, prostaglandins, your leukotrienes, your platelet activating factor, your bradykinins, tumor necrotizing factor alpha, and so on. Most of these inflammatory mediators have one thing in common, that they all cause increased vascular permeability. Okay. And at the same time, the bradykinin is known to induce pain in the inflammatory pathway. The major events which take place in inflammation are classified into vascular events and your cellular response. I will not go much in detail. I will just give a brief about this because most of us are quite aware of these events. So coming to the vascular events, whenever there is a tissue injury or whenever there is a noxious stimuli which occurs, the first event which takes place is some amount of vasoconstriction which takes place. In minor injuries, this vasoconstriction lasts for only about 3 to 5 seconds, whereas if the injury is more, then it lasts for about 5 minutes.
Do we have any issues there with your audio, Nida? I think the system's hanged. Just give me one moment, please. Sorry, did we have some issues, Nida?
Yes, sir. For me, it was coming as connecting, so I thought probably I'm not audible.
That's fine. If you could just share your screen again and continue, please. Now I think it's better. We can
Are
see.
you able to see my screen?
Yeah, we are able to see you. If you want to share your screen again, start sharing your screen and continue, please.
But my screen is already there, sir. But you're not able to see my screen?
No, we are not. Unfortunately, we're not.
Okay.
So you'll have to stop sharing and then share again.
Okay.
Yeah, that's better. Thank you.
Okay.
You can continue, Nida.
Yeah. Thank you, sir. Okay. So the cellular response is basically a leukocyte exudation which takes place, then followed by phagocytosis and tissue injury. Yes. The major local manifestations of inflammation are, this is the picture I've just put up so that we can see the difference between a normal and an inflamed tissue. The first major local manifestation of inflammation is vascular dilatation, which takes place. Here you can appreciate that in the normal thing, there is no dilatation of the arteriole or the venule, but here you can see there is nice dilatation of the arteriole and the venule. So this results in vascular dilatation. The second one being extravasation of plasma fluids, which we can see on the right side, okay, which is absent in a normal tissue. And the last one and the third one is leukocyte emigration and accumulation in the site of injury. These are the cardinal signs of inflammation. There are 5. The first being heat, the second being that is increase in the temperature, the second being the redness, the third being swelling, fourth being the pain, and the last one is loss of function. The increase in the temperature and redness is basically because of the increase in the vascular permeability there. The swelling is basically because of the exudation of fluid which is taking place. The pain is because of the excitation of the nerve endings which are present there. And if inflammation is not dealt out at the right time, then it probably can lead to loss of function. Now coming to corticosteroids. We need to, before we get down to corticosteroids, we need to understand what is the exact mechanism. How do these corticosteroids act? Okay, so these are basically hormones which are secreted by the body, which have an intense biological activity. These basically help the body to relieve or to fight against stress. These are released, the corticosteroids are excreted, or they are released by the adrenal cortex. And the corticosteroids can roughly be classified into mineralocorticoids and glucocorticoids. The mineralocorticoids, as the name suggests, mineralocorticoids, they basically deal with the mineral balance in the body, whereas your glucocorticoids basically deals with the it's called as glucocorticoids because it affects the glucose or the glucose levels in our body. The classification of corticosteroids, they are classified into short acting, intermediate acting, and long acting, depending upon their duration of action. The short acting are less than 12 hours, that is the cortisol and cortisol. The intermediate acting are your, which range between 12 to 36 hours, are your prednisone, prednisolone, and methylprednisolone. And your long acting drugs, that is greater than 36 hours, approximately 36 to 72 hours, are your dexamethasone and betamethasone. We will just compare the efficacy of different steroids, corticosteroids, on their anti-inflammatory effect. So here we can see the anti-inflammatory potency is maximum in the dexamethasone. Okay, that is comparable to betamethasone also, but maximum in dexamethasone, that is 25. And the sodium retaining potency of the dexamethasone is 0. That is, it has the you can actually say it has no mineralocorticoid effect. Okay, and the duration of action is also long, and the effective dose is about 0.75 milligrams. So now once we've understood the basic classification of corticosteroids, we need to know where exactly these corticosteroids act in the inflammatory pathway. The corticosteroids, as you can see here, basically they produce lipocortin, which is a protein which acts as an inhibitor for the phospholipase A2. Initially, we had seen that the membrane phospholipid gets converted into arachidonic acid by the enzyme phospholipase A2. So similarly, if the phospholipase A2 is not present or it is not there, then it's very difficult for the membrane phospholipid to get converted into arachidonic acid. So corticosteroids exactly do that. They release a protein which is called as lipocortin, which inhibits the formation of the activity of the phospholipase A2. Hence, there is no amount of phospholipase A2 present to convert the membrane phospholipid into arachidonic acid, and hence the entire inflammatory pathway is not set into picture. When I'm talking about corticosteroids here, I just want to compare with the NSAIDs. The NSAIDs block the inflammatory pathway at the cyclooxygenase. That is, they don't block it at the phospholipase A2. They allow the phospholipids to be converted into arachidonic acid, and once the arachidonic acid is entering into the cyclooxygenase pathway, it is at that step that the NSAIDs block. So hence, because of this, it is considered that the anti-inflammatory properties of corticosteroids are superior to your NSAIDs. So now when we know that corticosteroids exhibit such good anti-inflammatory effects, then why not use these corticosteroids for every patient or for every extraction? It has its good anti-inflammatory effects, right? But no, like they say, every good thing has, you know, accompanied bad thing, or everything has their own advantages and disadvantages. Similarly, the corticosteroids, although they have their anti-inflammatory effects, they also carry immunosuppressive effects along with them. Okay, so the advantage of corticosteroids being the anti-inflammatory effects being they decrease the leukocyte accumulation, they decrease the leukocyte function, they produce monocytopenia and eosinopenia, they decrease the complement pathways, they decrease the histamine mediated reactions. So by producing all these effects, they reduce the inflammation. So they have an excellent anti-inflammatory effect. But however, they cannot be used injudiciously. They cannot be used whenever we, even if they are not required, because along with the anti-inflammatory effect, they produce some amount of immunosuppressive effect. That is, by reducing the lymphocyte and monocyte function, by reducing the lymphocyte chemotaxis, by decreasing the complement levels, probably they are producing an immunosuppressive effect on the body. They're decreasing the healing capacity of the body. So when we are giving in our impactions, probably we're just giving a stat dose of Dexa. So might be the immunosuppressive effect is not that prolonged, but if they're used on a long run, then for sure these immunosuppressive effects play a role. So that is why whenever we're choosing, we need to choose whether we're giving the steroids wisely. It has to be given, even if it is a stat dose, it has to be rightly weighed against the pros and cons, and it has to be given only if it is really necessary. So now we will see why dexamethasone is the most preferred steroid as compared to others. It is because of, first one, it directly inhibits phospholipase A2. The second one is the redistribution of leukocytes to other body compartments, thereby lowering its concentration. So throughout, when I'll be talking today, I'll be talking about dexamethasone because it is the most preferred steroid, and we have been constantly been using this in third molar surgeries. So when I was going through different articles, there were certain inclusion criteria and exclusion criteria. So I've just put the Pellin-Gregory classification of the mandibular third molar, so that we can just relate that which impactions, like I told you in the starting, that when you're using corticosteroids, we need to weigh the pros and cons of giving a steroid. Okay, not necessarily every impaction requires a steroid post-op. Okay, so where exactly it is indicated, So to understand that, I've just put a classification of Pellin-Gregory, so that because in most of the articles, they've always told inclusion criteria based on the Pellin-Gregory classification. So before I tell you which cases actually require, I'll just give a brief about what this Pellin-Gregory classification is of the impacted third molars. It is divided into level A, level B, level C, class 1, class 2, and class 3. The level A, as you can see here in this, there is sufficient space between the anterior border of the ramus and the distal portion of the second molar. So the width between the ramus and the distal part of the second molar is is equal or is the same as the mesodistal width of the third molar. So there is sufficient space for the third molar. The second one, in level B, in level A, you can see that the occlusal surface of the third molar is at the occlusal surface of the second molar. In level B, you can see that the occlusal surface of the third molar is below the occlusal surface of the second molar, but it is above the cervical level. Whereas in level C, you can see the occlusal surface of the third molar is below the cervical level of the second molar. So as we go from level A to level B to level C, the difficulty index increases. Now coming to class 1, class 2 and class 3. In class 1, the width between the width between the anterior border of the ramus and the distal surface of the second molar is sufficient for the sufficient or is comparable to the mesodistal width of the third molar, so that there is enough space for the third molar to be there between the ramus and the anterior border of the ramus and the distal surface of the second molar. Whereas in second, there is insufficient space. Whereas in class 3, the third molar is completely within the anterior border of the ramus. So this I've just put up to see that as we go from level A to B to C to class 1 to class 2 to class 3, the difficulty index increases. How does the difficulty increase? It's because there is no enough space or there's not much accessibility for the third molar to be extracted. Hence, sometimes we even section the tooth and we take out. Now, how is this going to affect on my steroid? It is said that the amount of time taken or the amount of tissue injury which occurs is directly proportional to the amount of inflammation which is created. If I finish my procedure within 15 to 20 minutes or probably 10 to 15 minutes, then I would judge if I really want to give a steroid, because the amount of tissue injury caused is very minimal. But however, if I'm doing a class 2 level B impaction, then if I'm sectioning the tooth and taking out, then probably I would think, then my procedure prolongs from, 20 minutes to 30 minutes or 30 to 35 minutes. Then probably I would be justified by giving a post-op dexamethasone, because my procedure has prolonged, and that is directly proportional to the amount of inflammatory response which will take place. This is one of my case which I've just put forward. Here is a classical class 2 position B according to Pell and Gregory's classification. The Ward's incision has been given and the extraction, the bone guttering has been done. Here I did sectioning so that to take out the tooth. So my procedure was about 30 to 35 minutes. Okay, this is the suturing which was done. So this is basically to just tell you what are the indications or where exactly in which procedures you need to give dexamethasone. Coming to contraindications, there are relative and there are absolute contraindications of corticosteroids. Relative are peptic ulcers, diabetes, hypertension, renal failure, congestive heart failure, osteoporosis, tuberculosis, and any other infections. I'm not going to get down into details why they are contraindicated. They are basically because of the immunosuppressor effect, which the effect of corticosteroids on the systemic level, which is making them contraindicated in these patients. So if a patient has uncontrolled diabetes, or if the patient has uncontrolled hypertension, then I would preferably not give post-op steroid in that patient. The absolute contraindications are herpes simplex keratitis and Cushing's disease. Now coming to the different doses of dexamethasone. As initially I told you, there are many articles which have compared different doses. Okay, so here I'm basically going to compare 4 mg versus other doses. Philo et al. Compared 8 mg of dexamethasone with 4 mg and came up with a conclusion that 8 mg of dexamethasone was more effective in controlling the swelling and trismus, but not much difference in controlling pain. Another study, which was done by Augusto and Ho et al., reported no statistical difference between 4 mg and 12 mg. Whereas Grossi, GB et al. Also said, he also compared 4 mg and 8 mg, and the route which was used here was submucosal. Here also, Grossi, GB et al. Said that there is no significant difference between 4 mg and 8 mg. So that brings us to a conclusion that probably 4 mg can be a subtherapeutic dose of dexamethasone. Now, before we compare the different routes, before I go on to telling which route is better, before I compare the systemic, local, and in systemic and local, which is the best one, I would just like to throw some light on what are the different systemic routes available, what are the different local routes available, and how exactly it works. Systemic routes, I think more or less most of us are familiar with, okay? The first one being the oral route, then the IV route, which is given in the median cubital vein or the radial vein, and the IM route, which is given either in the gluteus muscle or in the deltoid muscle. Locally administered. This I just want to tell a little in detail about how we give this, so that when I'm comparing, we exactly know when I'm talking about end alveolar, what am I talking about, when I'm talking about intramesenteric, what am I talking about, and when I'm talking about submucous. The first one being end alveolar. As you can appreciate here, it is basically the dexamethasone powder, which is wedged into the extraction socket before the suturing is done. So the only advantage of the end alveolar is we're directly placing it at the site of injury. We're directly injecting it into the extraction socket. So whenever I'm talking about end alveolar, it means the dexamethasone powder, which has been wedged into the extraction socket before the suturing. Second one is submucosal. There are many articles which say, you know, for the submucosal, some articles say it is just into the buccal vestibule next to the third molar. Some say it is into the loose connective tissue adjacent to the sutured site. Some say it is just distal to the second molar after the suturing has been done. So basically submucosal means we are trying to deposit the dexamethasone just in and around the area of the extraction or where the tissue injury has been done. So we are just depositing the dexamethasone in and around the mucosa. We are not going into deeper. As you can appreciate here in the picture, it is just into the submucosa. It is just around, we are trying to deposit the dexamethasone around the sutured site. Next being the intramesenteric. Here we are giving it directly into the masseter muscle. We palpate for the masseter muscle and we are injecting into the masseter muscle. The difference between submucosal and intramesenteric are, in submucosal, when we inject, we see we should enter into the loose connective tissue and we don't see any amount of resistance. But when we are giving into the intramesenteric, we see some amount of resistance which is offered by the muscle. So that is how you can differentiate, because most of the time when we're trying to give intramesenteric, we end up giving submucosal only. So once you feel the resistance, then it is sure that you're into the masseter muscle. Then coming to intraosseous, this is this intraosseous technique was invented in 1922 by Drinker and colleagues, but of late it had not been used in dexamethasone. It was intraosseous anesthesia has been used for a long time. But however, I came across an article which is in 2019, according to which they have compared, I will be talking about it further also, I will be comparing the intraosseous with the submucosal. Before that, I just want to give, how do we give this intraosseous? It is a little technique sensitive. Frankly speaking, even I have never given an intraosseous dexamethasone till now. But just to throw on light, once the extraction is done, what we need to do is we need to take a 0.8 diamond fissure burr, and then we need to drill, as you can see in this picture, 5 mm distal to the extraction socket site, okay, the empty site, the socket site which is left. So we have to inject this we have to drill, we have to take that 0.8 mm diamond fissure burr, and we have to just create a drill inside, okay. You have to be very careful that the drill should not perforate, you know, and this drill should be given midway between the buccolingual plate, slightly erring more on the buccal side. Once you have created a hole in the buccolingual plate, you're always supposed to take a probe and you're supposed to check. There has to be no communication between the hole which you've created and the extraction socket. If you feel the probe is entering into your extraction socket, then it is said that you need to repeat the intraosseous injection. You need to give it a little more posterior. So that is why I said this technique is this intraosseous technique is very, I think it has a curve. You have to learn, and it's not the same. I don't know if everyone can practice that very well. So we need to see how this goes. So, and after that, you're supposed to see a 20 gauge, you're supposed to take a 20 gauge needle, and then you're supposed to infiltrate, or you're supposed to inject your dexamethasone in the hole which you have created. Now I'll be comparing. I have collected few articles, and I'm just going to compare how the different authors have compared what, and what are the conclusions they have arrived at. Yeah. So I'll be comparing different authors, different articles, and we're going to see what is the end result of it. The first article which I'll be talking about is Pappalardo et al., which compared the endalveolar route, the submucosal, the IV, and the intramuscular. Here, the pain levels were comparable to your IV, your intramuscular, and your endalveolar routes. Similarly, the swelling also was comparable, and the trismus was comparable in all the three routes. However, in this article, the results of your submucosal were not very great. They said the submucosal route is not very effective, probably because it is more hyperemic compared to the other. It leads to the faster absorption of dexamethasone from the site. So this article, however, mucosal route, it favored the IV route as the classical route, and also said the results of the endalveolar surprisingly were similar to that of the IV route. So here they compared 4 mg IV and 10 mg endalveolar, and they said that the results of the 4 mg IV and 10 mg endalveolar were comparable to each other, and they attributed the advantage of this endalveolar mostly because the endalveolar is actually inserted into the extraction socket, and it stays there for a longer time. So probably because of that, they said the effect of endalveolar is similar to that of IV. The second article, which is by Broccoli et al., compared IV with intramesenteric and oral. Here, the results were comparable between IV and IM in the pain region, and also in the swelling and trismus. It was seen here that the intramesenteric was much better as compared to IV, and here they attributed that trismus was much better as compared to IV, because probably here we are injecting the IM directly into the muscles. So there is some amount of advantage which is offered, and that is how the trismus is less as compared to your IV routes. So here at the end, they said 8 mg intramesenteric can be a good alternative for your IV route. The next article by Vivek et al. Here they compared 3 routes, that is IV, intramesenteric, and the submucosal. Here they said that the pain and the swelling was comparable between the intravenous route and the submucosal route. But however, here they saw again that trismus was less in the intramesenteric route for day 1. But however, surprisingly, they saw that after day 3, the trismus increased, or the trismus was more in the intramesenteric as compared to your IV and submucosal, and they attributed a reason that might be probably because we're injecting the dexamethasone directly into the muscle. There might be some amount of trauma which we are causing to the muscle, and that could lead to the increased amount of trismus which we saw after the 3rd day. So here they say that IM is a very good route, but however, when you're injecting the dexamethasone into the mesenteric muscle, you need to inject it at 1 ml per minute, very slowly, and only one prick or only one dose can be injected. So here they favored the submucosal, but they however said submucosal and intramesenteric are almost comparable to each other, and here the dose which they used is 8 mg. The next article is by Omar Walid Majid. Here again, The author compared the submucosal with the intramuscular, not the intramesenteric, it's intramuscular. Here it was given in the gluteus region. The pain was comparable between IM and the submucosal. The swelling also was comparable, but here, however, it was seen that the trismus was the results in trismus were much better in the submucosal route as compared to your IM route. Hence, the end result was that 4 mg submucosal can be a very good alternative for your can replace your intramuscular route. The next one is by the author Gopal Krishnan. Here the author has compared the submucosal again with your intramuscular. Here, however, the results were directly in the favor of the submucosal route in terms of pain, in terms of swelling, and in trismus here, in contrast to the previous study, they said that the trismus was comparable to both the intramuscular and the submucosal, and the author said that the submucosal route of dexamethasone does not have any direct effect on the muscles. Just because we are injecting the submucosal in and around the site or in and around the masticatory muscles, it does not mean that the submucosal is directly acting on the muscles. Probably because the submucosal is present very close to the surgical site, it is reducing the inflammation, and that is how indirectly it is reducing the trismus. But however, this author said that the submucosal dexamethasone does not have any direct effect on trismus. Here also, the dose used was 4 mg submucosal, and again the author said submucosal route can be an alternative to your intramuscular. The next one is by Covermet et al. Again here was compared the intraosseous with the submucosal. The previous picture which I had put up where I was explaining about the intraosseous, it is from this article. So this article is in 2019 where they claiming to be the first authors to compare the intraosseous route with the submucosal route. Here they said that the swelling was comparable the results were comparable between intraosseous and submucosal, but however, the amount of rescue analgesics taken were much more higher in the intraosseous, and the pain was much less in the submucosal as compared to your intraosseous. So this article also favored the submucosal route. Similarly, in trismus also, it was seen that the submucosal route offered better results as compared to your intraosseous. So, and this author itself said that the technique used for intraosseous is very difficult, and you need a lot of learning to give your intraosseous dexamethasone. So again here, the conclusion derived was 4 mg submucosal. So as you can see here, in many of the articles, still they're using only 4 mg dose of the dexamethasone as compared to your 8 mg. And the most favored route which is coming out, or the most favored result, the highest result coming out from all the comparison of the articles which I've done is the submucosal route. Now coming to systemic versus local. I've already spoken about what are the systemic routes, what are the local routes. Now, this was a very good article which is in the year 2013. Here, the very good comparison has been done between the systemic and the local, and the advantages and disadvantages of both have been very nicely written down here. So I thought I'll just put forward this article. Here, 5 treatment groups received dexamethasone, and 1 was a control which did not receive any dexamethasone. The routes which were compared are the intramuscular, which was given in the deltoid region, the intravenous, which was given in the vein of the forearm, the oral tablets taken as 4 doses of 1 mg every 6 hours in the first post-operative day, the submucosal injection. Here it is said that it is given just into the buccal vestibule near the surgical site, and the end alveolar powder, which is applied incrementally into the extraction socket just before the suturing has been done. Here it is seen that systemic dexamethasone, intramuscular dexamethasone show better improvement as compared with your oral route. But although here it was seen that the difference between oral, intravenous and intramuscular was quite comparable to each other. The only advantage of systemic is quicker effect with less amount of drug being lost. But however, the effect of oral dexamethasone on trismus trismus was somewhat better than the parental routes. That is, the oral dexamethasone showed better results on trismus as compared to your IV and IM routes. The locally applied dexamethasone, the submucosal dexamethasone showed a significant reduction of swelling on all post-operative results. And these results say that locally applied dexamethasone, be it in the form of submucosal or be it in the form of end alveolar or be it in the form of intramesenteric, provided good results in terms of pain, swelling and trismus. And here it was said that a subtherapeutic dose of 4 mg was valuable enough to reduce these complications. So when we compare the systemic versus local routes, the advantages or the classical route would always be the IV route because it provides.
Nida?
Yes, sir. Hello. 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 Hello, sir. Can you hear me? Hello. Hello.
Please continue, Nida. You need to unmute yourself. We can't hear you. Nida, we can't hear you. You need to unmute. Hello, Nida, can you hear me?
Can you hear me, sir?
Yeah, please continue, please.
Yes. Okay. So once we compare the systemic versus local routes, it is seen that local application of dexamethasone is comparable. Whenever we think about systemic versus local routes, the IV route or the intramuscular route is always the classical routes which we use for dexamethasone. But however, what I'm trying to focus or what I'm trying to throw light on is the submucosal dexamethasone or your intramesenteric dexamethasone can be an alternative to your systemic routes, because in most of the articles we have seen that compared to your pain, your trismus and your swelling, the results are comparable to your IV and your intramuscular routes. So why not use submucosal or an intramesenteric or a locally applied route rather than injecting the dexamethasone into the system. Okay, so these are the 4 questions which I had put forward in the starting of the webinar. So I'm just going to run through these 4 questions again, and then I'm just going to throw light. I'm just going to tell which is a better option according to me. But after this, I think we're going to open for the questions, and I think my seniors also who are present can throw a light and can tell what are their options or which is a preferred route or timing according to them. So the first question is timing of dexamethasone, whether it is pre-operative or it is post-operative. Few articles have even used intraoperative, but I'm not going to compare that. I'm going to compare only a pre-operative and a post-operative. The second one being effective dose of dexamethasone. I'm not going to compare with others. I'm just going to compare 4 mg versus 8 mg. The third one is whether systemic or local dexamethasone, which is a better and why. And the last one is the most favored route of dexamethasone. So first one, coming to timing of dexamethasone, whether a pre or a post-op of dexamethasone is given. According to me, a post-operative dexamethasone is much better as compared to your pre-operative. The first one being because it allows the surgeon to actually assess the need for injecting the steroid. As I told in the starting, although the anti-inflammatory effects of corticosteroids are very good, but along with the anti-inflammatory effect, they're also carrying the immunosuppressive effect. So that is why I said, whenever you decide that you're going to give steroid, you need to justify yourself why you're giving the steroid. So if I'm giving it post-operatively, I have enough time to decide whether the steroid is actually necessary or not. Initially, if you remember, I said, according to Pellin Gregory's classification, class 2 position B or class 3 position C, these are difficult impactions which would take a little longer time, and probably this could result in more inflammatory response. But sometimes it so happens that when we're doing the extraction, it actually does not take that much long. We might end up finishing much faster than we think. So then I would actually think if I really need to give dexamethasone or no. But if I've already given preoperatively, I cannot reverse back the reaction. I cannot go back. So once I've given, it's already given. So I would prefer always a post-operative dexamethasone because I have enough time so that I can assess whether I actually need to inject the steroid or I can avoid it. The second one being no further manipulation of the tissue, hence no loss of the steroid. This is applicable only in the local administered dexamethasone. That is when I'm injecting in and around, be it in the form of endalveolar, powder dexamethasone, or in the submucosal or in the intramesetic. I'm not further manipulating the tissues. So there is no loss of steroid from the site. So I need not increase my dose of dexamethasone when I'm giving post-operatively, because I'm sure once I've sutured the site and I've given my dexamethasone, it's just going to be there and it's going to cause its effect. The third one is there are two schools of thought. One say that preoperative dexamethasone starts acting even before or it is already present in and around before the inflammatory mediators come, or once the inflammatory mediators come into picture, the dexamethasone is already present there to act. But however, another school of thought say that there's some amount of inflammatory mediators are helpful, or they're needed there for the healing to take place. The extraction socket healing which takes place requires some amount of inflammatory mediators. So let's not block the entire inflammatory mediators by giving pre-op dexamethasone. So if you give post-operatively, there are some amount of inflammatory mediators which would have already been infiltrated there. So probably those inflammatory mediators can help in the healing of the extraction socket, and they will not they would not hamper the healing. So these are my three reasons why I always prefer a post-operative dexamethasone, but some people might not agree, and some people still give pre-operatively, and some people also give intraoperatively also, I've seen. But I would always prefer a post-operative dexamethasone because of these three reasons. The next one is effective dose of dexamethasone, 4 mg versus 8 mg. When I was enlisting different articles for comparing the different routes, there I had specifically put up the mgs so that we can compare. So there when I was comparing, we saw most of the articles had 4 mg dexamethasone. In one article, I even told you that the author said a subtherapeutic dose of 4 mg is quite enough. According to literature, it is said that to obtain an anti-inflammatory effect, the dose should be equal to the physiological quantity which is released by the organism. So according to this logic, a 9 mg is actually necessary to produce anti-inflammatory effect. But however, many meta-analyses have been done, many studies have been done which have compared 4 mg with others, 8 mgs, 10 mg, 12 mgs, etc. I've referred one meta-analysis which is done by Morashino Filha et al. According to him, it was actually arrived at a conclusion that a subtherapeutic dose of 4 mg dexamethasone is more than enough, and giving more dexamethasone in excess of 4 mg does not mean that the anti-inflammatory effect of dexamethasone is increasing. Some people feel that giving 8 mg increases the anti-inflammatory effect. So that is why I put forward this, because most of the articles say it is not so. A subtherapeutic dose of 4 mg is, however, enough, and it is enough for the anti-inflammatory action to occur. But however, actually the dose can be modified depending upon the area or the site where I'm giving. For example, if I'm giving IV or if I'm giving intramuscular, then I need to weigh my pros and cons very carefully, and I can always give a lesser dose, that is 4 mg. But however, if I'm giving in submucosal or intramesenteric, I can go forward and give 8 mg if I really want to, because this I'm injecting the dexamethasone locally in and around, and I'm not entering, the dexamethasone is not entering systemically. So that is why some few authors say that also, that the dose can change according to the dose can change according to the route which you select. So if you're selecting IV and you're intramuscular, then probably a smaller dose or a subtherapeutic dose of 4 mg can be used. But if you're infiltrating locally, you can use a 8 mg. But however, I would say a subtherapeutic dose of 4 mg is more than enough. Next, coming to systemic versus local dexamethasone. As I told you, most of the authors said that the classical route would always be your IV route, okay, because it offers faster onset of action and better bioavailability compared to any other route, okay. So there is no doubt that your IV route is the best route available. But why would we prefer a local is what we are going to discuss now. Some patients consider IV injections to be another invasive procedure, and giving IV injections can itself be challenging, and they have their own set of complications with the IV injections. Hence, it is always better to give a locally administered steroid, okay, because it is a simple procedure. It is a simple procedure. It is not very technique sensitive. As I told you, submucosal and your intramesenteric or your end alveolar is actually just in and around the tissues, or it is in and around the extraction socket site. So it is very easy to inject these, and very important is the area in and around is already anesthetized. So we don't even have to, the patient is pain-free also. We don't have to use another site. There is less chance of morbidity and all that. So these are the advantages of the locally applied dexamethasone as compared to your systemic. So I would prefer a local dexamethasone as compared to systemic. Most favored route while comparing a systemic and your local would be, according to me, I feel submucosal dexamethasone is a very good option, or it could be a very good replacement to your IV and your intramuscular dexamethasone. Why? Because a low dosage can be given, a 4 mg, because it is present in and around the site of injury. So it is locally available there. So I can preferably use a 4 mg as compared to 8 mg. It is a localized administration. I'm directly injecting into the area of the tissue injury. Short-term exposure and generates minimal adverse effect. Okay. Then it is quite simple. It is safe. It is less invasive as compared to your IV and your IM. It is painless because I told you it is in the anesthetized area already. So as this route offers a comparable therapeutic option to the systemic one, then I would, then the dentist and oral surgeons, I think, can think of it as an option, or can think of replacing the injecting of dexamethasone through the IV or the IM route. This is just a poster I've just put up so that we can concise the entire webinar, what I spoke about. This is dexamethasone, the mechanism of action, which I've already told. It acts, it basically blocks the phospholipase A2, and it is usually used for difficult extractions. It is used for Pellin-Gregory's class 2, position B, only for those extractions which are taking a longer period of time. As I told you, the amount of inflammatory response is directly proportional to the tissue injury or to the time taken. And according to me, as I told, a dose of 4 mg is sufficient, and post-operative dexamethasone is always preferred as compared to your pre-operative, and a submucosal, that is injecting the dexamethasone just adjacent to the socket or to the sutured site is a preferable thing. The advantages of the submucosal compared to your IM and IV are, again, it is a simple, painless, 4 mg is enough. It is the results achieved of submucosal compared to your IV and IM are comparable. It is inexpensive, it is absorbed faster, and it is less invasive as compared to others. So I would like to conclude that 4 mg dexamethasone given postoperatively reduces the postoperative complications following third molar surgery. And I would suggest submucosal is a better option, but still it is up to the audience to decide which, they want to still follow the classical IV and the IM, or they want to, follow the submucosal. Everything has its own pros and cons. But however, submucosal can be thought as an alternative to giving IV dexamethasone to deal with your pain, your swelling, and your trismus. These are my references. Thank you. So I can't hear you.
Thank you, Dr. Nida, for that very comprehensive brainstorming session about steroids and then the use of dexamethasone and its efficacy in management of third molar surgeries and its sequelae. We are open to the question and answers now. We will start with, we have on panel Dr. Sirajul Hassan, who is an associate consultant in King Fahd Medical City. He's known for his meticulous surgeries in cancer and trauma surgeries. Can we have him, please, on the panel? Siraj?
Sorry, can you hear me now, Nida?
Yes, sir, I can hear you.
Okay, you need to stop sharing your screen. I have unmuted Dr. Hassan as well. So, Dr. Hassan, can you turn on your video, please?
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa rahmatullahi wa barakatuh. I'm going to mute myself, and Nair and the speaker would take over for the questions. Thank you.
Thank you very much, Dr. Ali. We are open for questions now. I think this session, I think we've had the maximum number of doubts, and mashallah, it's really nice that so many participants are taking a proactive reason to join in the participation of the webinar. So the first question is from Dr. Salman Basha. Dr. Nida, he is asking the role of trypsin / chimeral fort in swelling. And then his question is, which is better in terms of steroids or chimeral fort in the management of the sequelae of third molar surgeries?
Okay, sir. According to me, steroids are always better in managing swelling as compared to your chimeral forte. But however, they have comparable, they have comparable actions. But however, I would always prefer a steroid.
Dr. Siraj, you want to add something to it?
Definitely, actually, steroids as compared to chimeral fort, which is chymotrypsin and trypsin, which blocks only the plasmin, which is one of the pathway. So I prefer for going to the steroids because it completely blocks the whole of the inflammatory procedure. Like it blocks the phospholipase A2. So it has a better efficacy as compared to chymotrypsin and trypsin. So as compared, even prednisolone or even cortisone is better as compared to chymotrypsin and trypsin. Not going even for a longer duration of dexamethasone. So I prefer definitely steroids as compared to chymotrypsin.
If we actually look at it in terms of the basic characteristics of the steroids and then the chimeral forts and the trypsin and chimeral fort, what they basically are is they are proteolytic enzymes, whereas steroids are immunosuppressive. Yeah.
Block only the plasmin.
Yeah.
Down peptides.
Yeah.
So it is a secondary mechanism, and it might be preferred for a small procedure like a simple extractions or like as Dr. Nida told, like a class 1 or a simple soft tissue impaction. But going for a more bony impactions and so the role of chymotrypsin and trypsin, it takes a longer time for controlling the anti-inflammation as compared to steroids. So that is the main thing in our practice. I don't know. So
I agree with you. Plus, the mechanism of action of the proteolytic enzymes compared to steroids is totally different.
Yeah.
Okay. We'll have the second question now. The second question is, the swelling usually reaches its maximum within 48 to 72 hours of the surgical procedure. The vasoactive amines cause vasodilation. Thereby, this is the question asked by Dr. Nadeem.
Okay, sir.
Hello, Nida?
Yes, sir. What's the
Yeah,
question?
the question is, swelling usually reaches its maximum within 48 to 72 hours.
Yes, sir.
So what exactly do we do? I mean, in your initial slide, you mentioned the efficacy of Dexa and betamethasone are same.
Yes.
But why is still the former one preferred? I think Dr. Nadeem wants to ask is, I don't know what exactly he means by why Dexa is preferred over betamethasone. Is that what the question is, Dr. Nadeem?
That's my question, yeah.
Okay.
Because one of our slides showed that the dexamethasone and the metamethasone have the same efficacy action. I think 75% or something. I forgot the numbers there. So they are in the same ring, in fact. So why is that Dexa is always preferred over betamethasone?
Okay, sir.
Basically, dexamethasone is given as an oral, as a systemic use, but betamethasone has less efficacy as an oral or a systemic. It has more efficacy in a topical. So betamethasone as a topical is more prolonged as compared. So betamethasone is used for other uses as compared to dexamethasone, which is used as an anti-inflammatory.
You mean to say betamethasone is not advocated? That is what you mean to in terms of oral route?
Freely available everywhere. Like many of the countries have banned betamethasone as a systemic or as a oral. It's only available as topical. So whereas dexamethasone, I think in whole of the world it is available as a systemic route, or even as a oral route.
So the bottom line, yeah, the bottom line, I take it as because of the availability you're saying, since Dexa is freely available, that is the reason it is used. That is what you mean to say.
That is the only reason. Otherwise,
Right.
if it's available, betamethasone also can be given. Like in US, it's available as IV route. So they also have compared betamethasone with dexamethasone. But whereas in India, I don't think so. It's available as other route, betamethasone. Or even in our country, Saudi Arabia, it's definitely banned. It's available only as a topical route.
Right. Thank you, Jazakallah.
So
yeah, the next question is, and also I think the group of corticosteroids, when we are in terms of dexamethasone, betamethasone, they actually, when you compare the anti-inflammatory activities with the other steroids, these dexamethasone and betamethasone are known to have less effect on or no effect on the fluid and electrolyte balance. So yeah.
Yes.
Okay. Let's take the next question, please.
Most of the time, the only available complication with dexamethasone is there will be like fluctuant CRP, C-reactive proteins, and sometimes even associated with excessive lactate, endogenous lactate.
Yes.
That is the only complication. Basically, what related like dexamethasone is basically mostly accepted as IV or IM or oral route as compared to other steroids like methylprednisolone or cortisone is only for the longer duration of action. Like one of the questions somebody asked, like usually it starts after 48 to 72 hours, the anti-inflammatory action. Like as Dr. Nida told, like if it's given as a post-operative, even I suggest it. Like post-operative is always better. One is like it depends on the surgery. Like if it usually it is required or not required. But second thing, the duration of action of dexamethasone is 36 hours. So it takes place like the usually anti-inflammatory effect of this dexamethasone is almost for 1 to 2 days if given as a single stat dose as 80 milligrams, or even we suggest even for sometimes for a bony impaction 16 milligrams. So it doesn't matter. So it is as good as almost for 1.5 days. So the patient will be relaxed, and once the patient, as we know, like physiologically or psychologically very relaxed, then most of the body produces like better endorphins and most of the secondary anti-inflammatory enzymes which take place, and they relax the wound. That is the main reason for dexamethasone as compared to methylprednisolone, which is only for 4 to 8 hours, 40 milligrams, or cortisone, it is only for 2 hours.
Yeah, also, but when we compare the potency of dexamethasone and betamethasone, I think dexamethasone has a better potency compared to betamethasone, number one. And also, when you look at the plasma half-life, when it comes to betamethasone, it has 300 plus minutes as a plasma half-life. But compared to dexamethasone, it is roughly around 150 to 200 minutes.
True.
Okay, let's take the second question, the next question. This question is from Dr. Asim Basha. He wants to ask, do you advocate any routine lab investigations before steroid therapy, especially in obese patients or patients prone to hidden kidney disease? Nida?
Yes, sir. So
You want me to repeat the question?
No, sir. I understood. Do you want to give any lab investigations before
that's
you,
right.
you want
Yeah,
to give
that's
a
right.
dexamethasone? I usually don't because first of all, dexamethasone what we're giving is just a stat dose, okay? And as I told, even if we give IV, the one stat dose of dexamethasone, I don't think it's going to affect like so much. The only question which I ask the patient is about diabetic and hypertension. And I don't feel the requirement of, lab investigations before giving a dexamethasone is really necessary.
I would like to add in this, like especially for the renal, hope you are hearing me, especially for, as Dr. Asim Basha is asking, for renal impairment. These patients usually are on some immunosuppressants like Immuron and ligand suppression and etc. And even also sometimes they are on low chemotherapy, cyclosporins, etc., which are known to have like neutropenia or thrombocytopenia, which can be problematic for if you give a dexamethasone or any corticosteroid. So usually for this, maybe like for these patients, usually if you want to administer any corticosteroids beforehand, it's better to have at least complete blood count to know the differential count, also to know the absolute neutrophil count and platelet count. So you don't have any post-op problems. Like dexamethasone is also known as the immunosuppressant. So there will be an additive effect of reduction in the worsening of the neutropenia or thrombocytopenia. That's the only reason. Otherwise, for a normal young patient without any known, even if the patient is obese, if the patient is not on any other therapies or any other problematic situation or the systemic any problems, it's not advocated to have a blood test. That is the only reason.
What I would like to add is actually before any procedure, I think the charting of patient history is very important in terms of any previous use of steroids, number one. And then I think the basic investigations are like FBC or urine analysis or blood glucose and also liver function test. But then when we're talking about these kind of routine investigations, they should be basically to investigate any adrenal suppression in terms of kidney ailments. Like, for example, if there are any hidden kidney ailments, they can be visualized or analyzed or investigated based on these adjunct investigative procedures, such as which involve the serum and the urinary cortisols, or also insulin tolerance tests or corticotropin releasing hormone tests.
Yeah,
There are actually, there are certain studies which showed that, in renal disease, the steroids can reduce the urinary protein levels and also help protect the kidney function. But however, some patients develop progressive kidney disease in spite of steroid therapy. Yeah, Shiraz, you want to add something to this?
Yeah, definitely.
Please.
As I told you, the history is basically the most important for all the surgical procedures, and hope even Dr. Nida, she had explained about that. And the important thing, what is related is, for the normal patient, young patients, we don't cover all these things. It is only required for the patients which are compromised, like systemic in the history if they are giving something. Like even I don't even advocate it for the patient only on hypertensives or cardiac diseases or on the any nephropathies and neuropathies, etc. But if the patient is on an end-stage renal disease or patient who is having liver disorders, etc., they are on some immunosuppressants. Nowadays, they give it. And even the patient, sometimes they don't even give the history like they are, and even sometimes they don't even know this is an immunosuppressant which they are taking because of the literacy level of our country as usual. So we need to just have an opinion and have a complete drug list about them. The most important thing is corticosteroids, when given with other immunosuppressants, it has an additive effect. That is the most important reason. So it might lead up like it is like a double-edged sword now. Like post-op, you are giving a dexamethasone or any other steroids. So if it is given, then you are giving for anti-inflammatory effect. But because of the immunosuppression, it might end up with a non-healing socket or other complications. That is the only reason what is required. But for a normal patient or even an obese patient or even a patient with cardiac issues or even hypertension, no need for any. Otherwise, it is related to the IN or IR.
I would agree with you in terms of, the steroids having more of immunosuppressive effects than anti-inflammatory. And I think, like you said, it is a double-edged sword, definitely, no doubt about it. And I think the question from Dr. Basha was for routine procedures. Like when we say routine procedures, like third molar surgeries, I don't think so. In terms of routine investigations, we would like to advise any particular investigations as such. Even in terms of, if it is a hidden kidney, I think we will get to know only in case of routine investigations as well. Okay, moving ahead, the next question is from Dr. Nadeem. He asks, how do we plan this medication if the patient is on active antifungal treatment?
That was beautifully put forth by Dr. Nida in the last slide, like post-op planning, pre-op planning. So it is like every time it is better to have a post-op dexamethasone. What I prefer.
Okay.
Surgeons, they prefer it is post-op.
Now, what Dr. Nadeem wants to ask.
You are hearing me?
Yeah, I can hear you, Siraj. Yeah, I think we just lost you for a moment there. The question from Dr. Nadeem is, how do we plan this medication if the patient is on active antifungal treatment, which might be overlooked during a patient history? And if we have to give oral route, should we give a stat dose or start how many days prior to treatment? If intramuscular route is given, can it be given prior to surgery? Did you get the question?
For this, I would suggest one stat dose is enough for all the minor procedures. Even if it is maxillary sinus lift procedure, it is one stat dose. What do you? I don't think so. You don't have to give it for 3 days, 4 days, or 3 doses. We are not doing orthognathic surgeries locally. I don't think so. Nobody is doing, or anybody is doing even. If it's trauma which is getting done in clinic, like some they do it like submental fractures or angle fractures, it's okay. You give it for 3 doses, but normally one stat dose is enough. And increase the dose, 8 milligrams, 16 milligrams, 12 milligrams, it doesn't matter. All have the same efficacy. So increasing the dose, that means the more amount of concentration in the serum, that's it. So that is the only one thing, in my opinion. I don't know what is the other, if you have any other opinion regarding this.
I agree with you in certain, to some extent, but the question was, in case of the active fungal and anti-fungal therapy, which the patient is already on, and then the patient forgets to add to his history, how exactly do we manage? Was the question. I mean, do we change the steroid therapy, or do we avoid the steroid therapy, or do we add up the steroid therapy?
For antifungal, usually it doesn't matter. Steroid doesn't interact with antifungal agents except for itraconazole or voriconazole, which are given, or amphotericin B, which is given for patients who are on immunosuppressants and or who who are suspected to have aspergillosis or mucormycosis or any other, the other commensalic infection. But normally, miconazole, all the other, whichever is available, clotrimazole, they don't interact with dexamethasone.
Yeah.
Except for these three, itraconazole, voriconazole, or amphotericin B, which are the drug of choice for mucormycosis or aspergillosis, or the grave
disease
infections in immunocompromised patients.
Oh.
So for him, again, the history comes. So the patient is already on immunocompromised agents. So that is the one which is interacting rather than the antifungal agent.
Yeah, it'll just add up to the synergistic effect.
Yes, that is the only reason. But normally, if they are taking the normal miconazole or clotrimazole, fluconazole, I don't think so. It should have any problems because there are no studies also suggesting they have any problems with the antifungal agent.
Okay. He further goes ahead to ask a question in terms of if intramuscular route can be preferred prior to the surgery so that the peak plasma level is reached for the complete availability. Nida, your opinion on this?
Yes. So
yeah,
same. Yes. Preoperative intramuscular, same thing, sir. As I've compared it throughout, okay, giving preoperative, that's the only advantage of preoperative giving, be it any route, is that the plasma levels are already, there is high plasma steroid level. So even before the inflammatory process sets in, we have the dexamethasone present there. But however, like I told, why I would prefer a post-op is because, as I told you, if my procedure is not that difficult, or my procedure is not long enough, then I still have a chance of not giving the steroid. So, but if you're actually very short, like if in a Pellin-Gregory classification it is a classical class 3 with position C, then you might as well give preoperative intramuscular, and it serves its purpose very well.
Okay. The next question again is from Dr. Nida Ahmed. He wants to ask what factors are considered while deciding the route of administration of dexamethasone.
It is only the surgery, the difficulty encountered by the surgeon, and sometimes if the patient is having, I would like to add, like preoperative is preoperative corticosteroids are sometimes needed. We need it in our hospital if the patient, like usually has sometimes the lingually erupted third molars and has a risk for airway. It's better to have a pre-op which controls the airway as well. So for that is the only reason. Otherwise, it is purely dependent on the surgeon's choice, the route of administration. But post-operative is usually the best time to administer, and as per our experience. And the best thing is like also IV, because IV, it is immediate effect as compared to IM, which takes time to get the effect. It takes around maybe 10 minutes to 15 minutes. Or as compared to oral, it takes like almost 30 minutes. So IV is the best choice.
Okay, so you say IV is the best route of administration, but whereas Nida, I think she would say submucosal is the best route of application for dexamethasone. Yeah, Nida?
Yes, sir. That's why I told in the end, I have just put forward a view. I know IV is the classical route. I've also been following during my PG time. But once I started following the submucosal, I saw that the effect of submucosal was more or less the same as compared to IV. And initially, when we were learning the IV technique, it was quite difficult. It was a little difficult as compared to a submucosal. So we always needed, a sister or somebody to just be there to guide us to learn the IV technique and all that. But for submucosal, it was not like that. It was very easy. So I've just put forward my, opinion about submucosal can be an alternative, because it has almost comparable results to your IV. So why not give a submucosal, and I've always seen that, whenever after the extraction, the patient is already, done with the extraction, and we tell the patient we have to give you an IV injection. So we've always seen the fear in the patient also, why an injection extra oral? They don't understand sometimes they do not connect to it. They're like, buy an injection, So once we're giving it intraoral, and I just tell them, I'm just going to give another, a steroid just to reduce your swelling in and around. So they're quite okay with it. Okay. So that way there are pros and cons. I would somehow prefer submucosal, but IV is
submucosal. I'd like to add a point here. Like submucosal is definitely an easy and technically very easy, especially for. But submucosal, there are studies suggesting like methylprednisolone 40 milligrams is better as compared to dexamethasone. And there are studies also stating that like methylprednisolone has an equal efficacy as equal to dexamethasone. You don't have to go for dexamethasone because methylprednisolone is much cheaper as compared to dexamethasone. And in fact, like we have recently have some like hydrocortisone oral cream. Hydrocortisone oral cream, nowadays we are advocating it for orthognathic surgeries. We don't even advocate it for in our hospital. We are applying over the lips and the labial mucosa, and it has the same equal efficacy like most of the times. Orthognathic surgery, E41 osteotomies, and even BiSAG in the BiMAX surgeries, we are applying it. And post-operative, patient is excellent, no swelling at all for 3 days. So it is the same. But as per the gold standard for dexamethasone is IV.
All right. The next question is again from Dr. Nida Ahmed. This Nida Ahmed might be a different Nida Ahmed. He wants to know, is dexamethasone phosphate?
Curious.
Yeah. I'm assuming that this is a different Nida Ahmed. We have a lot of Nida Ahmeds in our group. The question is dexamethasone phosphate better than dexamethasone sulfate or vice versa? Please explain its pros and cons.
I would like to explain this. Like, I don't think so. There is dexamethasone sulfate. There is phosphate and acetate. Acetate is for only IM. Phosphate can be both used as IM or IV. Otherwise, there is no any advantage or disadvantage.
I agree with you totally. There is no, there's no sulfate. There's acetate.
What we need is dexamethasone. We are not worried about phosphate or acetate. Only the route of administration. Because
I think the addition of sulfate or acetate only changes the route of administration. The acetate is basically for intramuscular, and like you said, the phosphate is either for IV or intramuscular. The next question is from Dr. Abid Amin Lankar. And he would like to know, can we give Dexa to revive from syncope?
I would like you to answer because we have a better, better drugs and better techniques also to revive a patient. Why Dexa?
Nida, would you want to add something to it?
Similar, sir. I'd
say, like you said already, steroid is a double-edged sword. And then when we can manage it with simple stuff, why we have to go for a higher end,
We can use simple ammonia. No need even for dexamethasone or even atropine. I mean, 1:100, 1:1000. Adrenaline also is not required for our syncope usually. I hope you agree all. Like simple ammonia is enough for us. So
I agree.
It's out of question for us.
Anyway, this is a question anyway. Again, the next question is from Dr. Salman Siddiq, and he wants to know, is dexamethasone absolutely contraindicated in patients with long-term medications? If yes, which medications please specify?
It is, I told you, Imuron, azathioprine, the patients on arthritis who are taking their medicines for rheumatoid arthritis, patients on chemotherapy. And I'd like to add, like most of the patients nowadays, especially male, above 60 years, they are on oral bisphosphonates, like alendronic acid. So you should be very careful for this because usually we end up, a lot of patients we have come across here, like they are on alendronic acid 40 milligrams orally since maybe 1 year, 2 years, and the patient doesn't even know this is an osteoporotic drug. So if you are administer corticosteroids for this type of patients, definitely you will go for a big dose. The patient might come up with a big wound, non-healing wound and exposed bone. And also I'd like to add, if the patients have undergone stem cell therapy, bone marrow transplantations, especially like this, so it's better to have a opinion from the hematologist usually, because the patients usually are on corticosteroids beforehand. So, and for their immunosuppressions along with their other immunosuppressive drugs. So it will have you don't usually require dexamethasone or corticosteroids. Basically, what we have seen, like administering corticosteroids in a minor oral surgery, not only for impaction, minor oral surgery, it is good to administer it in normal young patients who are not on any other drugs, or even you can go up to diabetes or hypertension. But other patients, like oncological patients on BMTs and all these osteoporotic patients, it's better to be safer side to go for as we have other like chymotrypsin, trypsin, or even ibuprofen is enough.
Yeah, I agree with you in terms of osteoporosis and then the administration of steroid therapy. I think you have to take a step back and then evaluate the pros and cons and then prescribe. And also in patients with psychosis and epilepsy, I think we have to take a little step back and then take a physician's consent in terms of administration of steroids, because it's known to increase the
psychosis and epilepsy. I would prefer to give steroids pre-op, because it's better for them, because usually they have an airway issues. So dexamethasone is a wonderful drug to manage an airway.
Yeah, and the beauty about our treatment is only the drugs are only not long term, but then it's very short term. Yeah, it's only on an ad hoc basis as and when we do the surgery, and then some people prefer it, some people don't. Yeah.
True.
Yes.
Yeah. The next question is from again Dr. Nida Ahmed. Can we give parenteral route on day of surgery and carry on with oral route if a difficult procedure is done? And anticipating swelling and trismus, should we taper the oral dose gradually?
I would like Dr. Nida to answer this, because she already explained it.
Yes. Yes, sir. So I think just giving a parenteral dose, that is one stat dose of be it IV or IM or submucosal or anything, dexamethasone is quite enough to deal with the anti-inflammatory process or to combat the swelling which is there. I don't prefer giving a combination of IV and then following it with oral dexamethasone. As I told you initially, in combination with the anti-inflammatory, it always carries the immunosuppressive things. So that's why I would always prefer one stat dose. Or if you're giving oral, then just continue oral, but not a combination of these two.
In my experience, like one stat dose.
Okay. One stat dose.
Yeah, okay. One stat dose of IV is enough. No to further have any oral dose or anything.
Actually, yeah, our procedures don't require the tapering of the dosage, because it's just a single dose, which makes a lot of difference. The
even
next question.
Even for 3 days, dexamethasone or any other corticosteroids can be given. The tapering issue comes only if you are giving more than 5 days.
Yes.
Yes, that's for your major procedures, like Sir said, your orthognathic surgery, your trauma cases. There actually
the maxillofacial surgeries, yeah.
2 doses.
Yes, sir. But for a simple third molar surgery, I think one stat dose is more than enough.
Okay. The next question is from Dr. Asim Basha. He would like to know in incidence of steroid abscess post injection in any routes. I mean, can we give steroids and incidence of steroid abscess?
Because I don't have any idea about submucosal or submesetric. I would like Dr. Nida to answer.
Nida?
Yes, sir. The question was?
The question was the steroids and the incidence of steroid abscess post injection.
So I've not come across anything like this. I will just look into this and just put it on the group if I come across.
Yeah, even in my personal experience, I think I haven't come across an antibioma or a steroid abscess, after the injection of the steroids. But then we would like to ask Dr. Basha himself, in case if he has any experience pertaining to this. Basha bhai, are you there? Basha bhai?
Yeah, I'm here.
Can you please elaborate on your question, please?
Yeah, see, actually, there's a very commoncomplication post steroid therapy in patients with OSMF.
Yes.
Yeah, post that was this. Usually, this sterile abscess occurred.
With OSMF, it is very common usually.
Yes.
We have come across, but for a normal patient, it is very difficult to have a
Yes.
sterile
Just wanted to find out whether this is there. That's the reason.
No, in terms of the management of OSMF with intralesional steroid injections, there are certain reports which say there is a formation of sterile abscess. But then in terms of the routine third molar extractions and then the injection of steroids leading to sterile abscess, I don't think so there's any documented literature on it. Do you agree with this, Siraj?
Also, I like to add, like oral submucous fibrosis, we are not using dexamethasone. We are using triamcinolone acetonide.
Triamcinolone acetonide, yes.
Which is much more potent as compared to dexamethasone or betamethasone. And it is almost like, most of the times, because of the sterile abscess, what we encountered, because usually in the initial days, even we used to have it, is basically what I have understood. Like I have 2 cases of sterile abscess post OSMF. The basic reason what I have understood is, like we get a lot of resistance while we are injecting in that fibers. Okay, so we are trying to push it, so it becomes a bolus. So triamcinolone acetonide as a bolus sometimes gets infected. That's it. So otherwise, when we are giving slowly the injections, like a small, take your time, one minute up to 1 minute, 60 seconds. So you'll never end up with this sterile abscess.
Thank you very much. Thank you.
The next question is from Dr. Nida Ahmed again. Mashallah, Dr. Nida Ahmed has a lot of questions to us.
He is the only.
Yeah, he wants to ask athletes who are on anabolic steroids, are there any interactions with any of the steroids mentioned by you, Dr. Nida?
Of course, they have an interaction, but a stat single dose doesn't have any problem. If you give it as a long term, definitely and also the athlete is taking anabolic steroid, then definitely you need to ask the patient to stop anabolic steroid. But as earlier we told, and we accept it, maybe all of the participants accept it, like for all the minor surgeries, it's only a stat dose, and stat dose does not have any problems with it.
But would you, in your general practice, Nida, double the dosage in case the patient is on anabolic steroids?
No, sir, I would not double the dose. Like sir said, I agree with that. We're just giving a stat dose, so it will not cause any much interactions or anything unless and until I'm putting the patient on oral drugs. So I would not double it on this.
And also, is it because of the dosage that you use? I mean, 4 milligrams compared to the other milligrams of dosage? Yeah.
Yes.
Okay.
Yes.
The next question is: it is always necessary to give dexamethasone following third molar extractions? This question is asked by Dr. Ali Mubarak.
Is it always necessary?
Yeah, is it always necessary?
It is never necessary.
No.
It is fully based on the surgeon's choice.
Yeah, it's like I say, I think it's a personal preference whether you want to give steroids or no. But then there are a lot of studies which say the effects on the sequelae of the third molar extractions compared to the swelling or pain and trismus. In patients with steroids, they say the patients are more comfortable if you put them on steroids. See, there's no harm in not giving them steroids, but then when it comes to patient's comfort after the surgery, they would prefer to be put on steroids. Otherwise, there's no absolute indication that says you have to give steroids in every routine third molar extractions. Yeah,
I agree. It's basically the surgeon's call. That's why
but
I said
sometimes in the patients, especially in our country, in India, if you tell them we want to give, because every patient have to be known, like it's our duty to tell them we have to give this steroids, whatever. But when you come and tell them like we want to give steroids, then suddenly they will tell, what, come on, steroids, why steroids for this procedure?
Correct. Correct.
So that is that will cause them a psychosis. But usually for minor procedures, I have never
I feel it becomes very pertinent to keep the patient informed in terms of the sequelae of third molar surgery or any surgery, as a matter of fact, intraorally. You know, that the patient might experience some amount of pain or swelling or trismus, which is again very subjective, because these three sequelae can be, you know, modulated or reduced by the handling of the tissues during the surgery itself.
Yes, that is the most important thing, handling the soft tissues, the amount of care you are taking.
Used for retraction of the soft tissues, yes.
Healing.
Yes.
And but I want to add one more point for your patient will be much relaxed. If you want to give dexamethasone, we have a much better drugs for pre-medication for this patient, like anxiolytics,
Anti-anxiolytics.
And we have even a small low potent benzodiazepines like alprazolam, or even the low dose diazepam can be given to relax the patient as compared to dexamethasone if you want to really relax the patient.
But the problem with this alprazolam and then the other anti-anxiolytic drugs, they are not over-the-counter drugs. It makes more sense in case when we are operating or doing the procedure in the OT under general anesthesia, it makes more sense. But under regular LA procedures, yes, when the patient is very hypertensive and then, you know, hyper anxious and then fidgety, it makes more sense. The next question is from Dr. Bhavesh.
Dr. Firdaus, can I just come in?
Please.
Regarding to my previous question, can you just elaborate? I'll just refine my question. See, my question was, if we have few bodybuilders or athletes who are on anabolic steroids, and default these guys have their systolic blood pressure on the higher side. So my question is, any of these steroids given to them, default a stat dose or a day before or after surgery, will that not increase his blood pressure more? Are we looking out for any post-operative severe bleeding? If the pressure is increasing, don't you think there might be some bleeding tendencies? That is what I'm trying to, ask. If any of you guys can, highlight this, that would be great.
If the patient is already on anabolic steroids and you want to control the steroids, or you want to
exactly.
Yeah, that is what I told. Like, if the patients are on anabolic steroids, usually they have a hypertensive, or it's based on their medications and the workout they perform or whatever they are doing. So basically, when they are coming, we would like to know what is their status. We usually take the vital signs and etc. So it doesn't matter. Like stat dose of there are studies stating, like, if the patients or athletes or anybody who is on anabolic steroids, and if you are giving a stat dose of 8 milligrams has no effect on this anabolic steroids. If the patient is being given for a longer term, then it's a problem. More than 3 days. If you want to prescribe, if you are thinking of prescribing corticosteroids for more than 3 days.
Okay. What is the window you're looking out for systolic pressure here?
Systolic pressure usually up to 140 is normal. 140, 150 is normal for
I think most of these guys, because generally I've seen in my practice, most of these guys who come with anabolic steroids, they have the systolics anywhere between 140 to 160. They are always on the higher end.
Usually they have 50 to 160.
Yeah, exactly.
If I can just interject here, I think Dr. Nadeem, are you worried about the bleeding caused due to increased, hypertension? Is that what you're increased about?
I might go for both, bleeding due to hypertension or complications associated to hypertension, because will that stat dose, since Dr. Siraj has said it has no adverse effects in that single dose, what I mean to say, if it is used adjuvant, if it is used in combination with the anabolic steroid, at that moment of time, will the systolic spike?
No, it will not spike. It will be the same, because for those patients, we consider baseline as a higher. We don't consider normal 180 or 80 systolic up to 120 to 140. We consider them 140 to 160 as a normal. Like some farmers, even there, because of them, their type of activity, we consider their systolic pressure on a higher side, it's normal. And by the way, systolic pressure, if it's on higher up to 180, it doesn't cause bleeding. It is the diastolic, which is more important for us. If it is even above 90, then usually you end up with bleeding. And considering the complications or anything adjuvant you are thinking like it might cause as adjuvant complications, for the stat dose, it should not happen anything. And we have come across all this patients.
And actually, when we look at patients with hypertension, the earlier school of thought said the use of vasoconstrictors in LA was contraindicated. But the latest research and then the evidence says there's no need for any change in the local anesthesia. You can use the regular with vasoconstriction basically because the idea was the secondary bleeding would be because of the secondary vasodilation after the effect of LA wears out. But how much of the secondary vasodilation are you worried about that it will lead to? I don't think so. The bleeding will be life-threatening in terms of even if major vasodilation occurs. I don't think so. The bleeding is so major that we really have to be worried about it.
Yeah, because sometimes like if the diastolic pressure is above 90, 95, then we end up with a lot of bleeding, which is sometimes dangerous. But systolic pressure, it should not have a problem because systolic is not a venous return. It is the diastolic, which is the return. So that will have a major gush of the supply to the capillaries. So all the capillaries open. So that is what we need to keep in point. And definitely anabolic steroids at single stat dose, it doesn't cause any problem and nothing to worry about it.
Sorry guys, I'm pumping in a lot of questions. Sorry about that.
All right. No, the next question is from Dr. Pervez. He would like to ask, instead of injecting submucosal immediately post-operative, what could be the efficacy if 4 milligrams of dexamethasone is directly loaded into extraction socket? Will this have any adverse effects? Nida?
I have not come across any studies where we are directly injecting it into the extraction socket. Like if we are injecting into extraction socket, then how are we just going to, just put it inside the extraction socket? I don't think so. It's going to stay there and it's going to lead to more absorption there. Unless and until if you want to give it actually into the extraction socket, then probably you can think of the intraosseous, method of injecting it there. And directly injecting inside the extraction socket, I've not come across. It's just into the submucosal would always be a better option, giving in and around.
Now, there are studies which say the placement of dexamethasone powder.
Powder, yes, sir. I told that end alveolar powder, yes, and
slides, yeah.
End alveolar powders, you can wedge it into the extraction socket, and many articles have compared the end alveolar with the submucosal also, and they have said the results are comparable for the end alveolar and the submucosal. But the only thing which is seen in one of the article is that the pain levels in end alveolar were surprisingly seen that the rescue analgesics taken by these patients were more as compared to your submucosal. Probably this could be because you're wedging in the dexamethasone powder into the extraction socket. That could lead to some amount of stimulation of the nerve endings, which could cause pain and discomfort to the patient. So that is why when compared end alveolar with submucosal, they said this can be a possibility. So there they have said in that study that analgesics taken by end alveolar was slightly more as compared to your submucosal. But however, that can be a very good option, end alveolar as compared to your IV also, because they say when you place it end alveolar powder inside the extraction socket, it leads to sustained and longer duration of your release of your dexamethasone as compared to your submucosal, because submucosal is comparatively a more hyperemic area and leads to faster absorption of the steroid from there.
Well put, Nida. Dr. Siraj, you want to add something to this?
Yeah, I would like to add, like, if you're putting the powder dexamethasone, here, why don't you add like chymotrypsin and trypsin? They are much better as compared to dexamethasone. because they are proteolytic enzyme breakdown. So they have a better efficacy in controlling as compared to dexamethasone, because dexamethasone, even the initial pathway is also hindered, whereas in the chymotrypsin, it is only the plasmin which is hindered. So which is what we want. We don't want the plasmins to come out. So that is the where the inflammatory transudate and exudate start accumulating. So that is one advantage like chymotrypsin has over dexamethasone.
Right. We have a question again from Dr. Nida Ahmed. In diabetics, as mentioned, not to be used, why are we even concerned if the glycolated hemoglobin concentration is under control? And he also goes on to ask, the random might spike for a couple of days, then settle down accordingly. Should we really need to have a second opinion with the physician?
So for the stat dose again, we don't need any other intervention or any other consultation for dexamethasone. And in fact, you can lower down the dose to 4 milligrams or even 2 milligrams. It has the same efficacy of 8 milligrams or 16 milligrams, because for our procedures, it's a minor surgery. We are not doing a bony procedure. We are not breaking the bones. So to get a proteolytic or osteoclastic activities or transudate or exudate to come in place for a diabetic. But yes, if the HbA1c is about 10.5, and if the patient is having random blood sugar above maybe 20 millimoles, or it is almost equivalent to 360, 375 milligrams of RBS. And so for those patients, even steroids as usual, like it's a relative contraindication unless they have any airway issues or any other things. So for a stat dose, again, for a diabetic patient under control, diabetes under control on patients having medicines, 2 milligrams, 4 milligrams are very safe to be used. No issues at all for me. And I don't know what you have any other opinion.
Yeah, actually, I get into a lot of controversy when it comes to HbA1c. I always feel that this glycolated hemoglobin concentration has absolutely no relevance when it comes to the day of the particular day on the surgery, because this level is only the measurement of the past 90 days,
Yes.
And then it has no relevance in terms of how the prognosis is going to be. It only suggests how your sugar level was in the past 90 days.
True, but the issue is HbA1c shows whether the patient is uncontrolled or controlled diabetic. That is the only thing what we get.
Yeah, that's in the past 90 days.
The sugar level is the most important thing. That's why
I agree with you here. I agree with you here when you say the RBS is very important at that particular time. Yeah.
It should be below 350 milligrams. That if it is above 350, then it's questionable to give corticosteroids. 350 doesn't have any problem. And also, if the patients have type 1 diabetes, it's better not to give steroids. In type 2, it's always better. It's like a normal patient. They are just a normal patient. Because type 1, the problem is pancreas is totally non-functional. So the steroids will act as a super additive immunosuppressant for them. So it's better to take care of those patients.
Nida, is diabetes absolute contraindication?
No, sir. When I put up the slide also, it was under the relative contraindication. And as sir said, it is usually uncontrolled diabetes, which is a relative contraindication again. So if it's a controlled diabetic or it's a controlled hypertension, you can still go ahead and give a stat dose of Dexa. It's only for uncontrolled diabetic, which is.
Very good. I think this is a continuation of the same question from Dr. Nadeem. What he would like to ask is, Dr. Fayaz would like to ask is it safe to give steroids in patients with moderate glycemic control but on insulin?
Yes. Yes, sir, we can.
Siraj? Siraj?
I didn't get you.
Oh.
I didn't get you.
Yeah, the question was, is it safe to give steroids in patients with moderate glycemic control but on insulin?
Definitely. If the patient is, nowadays insulin is being given even for type 2 diabetes or type 1. If it's type 1, I would never go for dexamethasone or any other steroids. If it's type 2, Definitely. And with the moderate control, I don't think so. Even at that rate, the stat dose doesn't have any problem. So you can go ahead with the stat dose. Stat dose is not an issue for any of the conditions except for immunosuppression.
Okay. The next
Dr.
question.
Firdaus, Dr. Firdaus, yeah, sorry to interrupt. Yeah. Coming back to my question, you just mentioned in particular about HbA1c. It is not very relevant on the day of the surgery for you. That is what you mentioned. That is what I understood from you, right?
Yes, yes, yes. I stand by
Yeah.
it.
So if I have understood correct, if HbA1c is not relevant, if is a poor indicator, don't you think it changes the entire outcome of the surgery?
Okay, let me put it this way. When do you decide not to do a surgery on that particular day? For example, are you more concerned about your HbA1c levels or your RBS levels?
The RBS levels might just spike because of his diet pattern also on that particular day.
Okay, okay.
Okay.
So if, for example, if your RBS is more than 250, are you going to go ahead with your procedure or no?
No, see, I would, correct me if I'm wrong, if the patient is diabetic, if the RBS is showing around 250, 260, even if I'm operating on that particular day, I can increase his oral dosage of anti-diabetic drugs on that particular day and get his glucose levels down.
But as dentists, are we allowed to increase or modulate the diabetic drugs?
No, we are not. So that's what, if I have to refer him back to the concerned physician, the physician would, emphasize on HbA1c. If he is under poor control, anything above 7, I think the American Diabetic Association recommends anything below 7 is appropriate candidate for any surgery to risk any kind of infections.
If I can break it down this way, when we are actually doing in terms of, for example, if a non-diabetic over a period of 2 decades, and then his RBS is 250, and then if his HbA1c is anywhere between 8 to 9, and then since the patient is a long-term diabetic, I think his base level of RBS will be anywhere between 280 and 270.
Yeah, agreed, correct.
So you cannot expect that patient, a non-diabetic for over 2 decades, to have a RBS less than 200.
No, that's what I'm saying. So why aren't we giving importance to HbA1c? This is my question, right?
See, the glycolated hemoglobin, I think we had a very detailed discussion in GDP a couple of months back. And then I had posted articles, also relevant articles to support my claim. What I personally feel is the HbA1c is a retrospective evaluation of your sugar levels, whether it was under control or not. But in terms of surgery, we have to be worried about the prognostic values. And then HbA1c is not a prognostic value. But when you're actually considering the 90 days, what I would suggest is you have to take a glycolated albumin concentration rather than hemoglobin concentrations. Because the glycolated albumin concentration is anywhere between 30 days. I would consider the 30 days subjective value than the retrospective 90 days value.
Okay.
I would like to add here, what Nadeem wants to know, like HbA1c, is it worth or not worth, right?
Yeah, I think there's a very simple way to put that, Siraj.
Usually, the first way, like what we do, like whenever the patient comes, if he's a known diabetic patient, what we do, we just check first is the random blood sugar, right?
Yeah.
So if the random blood sugar on that day, and forget about HbA1c, if the patient doesn't have HbA1c on that day, and the patient, you are checking random blood sugar on that day, and it is above 350. So you immediately stop. Like you will tell the patient, I will not proceed for the surgery, and send the patient for HbA1c. That shows us like whether the patient has a controlled medications, because HbA1c, why it is important for us is basically the drugs, what the patient is taking, the anti-diabetic drug, whether the drugs are controlling the patient's diabetic level or not. So that is the major importance of this HbA1c. So it is not relevant to our surgery, what as Dr. Nair Firdaus is putting. But RBS, random blood sugar, is the most important thing. If it is below 350, you go ahead and do the surgery, forget about HbA1c, nothing. But if it is above 350, you send the patient back HbA1c. That means you have to send the patient back to his physician stating that his diabetic control is not under control. He is uncontrolled diabetic. His medications have to be changed, and they will take care of the medication and then send the patient back to us with the controlled HbA1c After that, which we see like RBS, and on that day RBS, if it is under control, we do go ahead and do the surgery. Then
You
in
said
some,
350, Suraj? You said 350?
yeah, we follow 350. The recent is 350 is the normal.
Okay. That's quantum leap for Indian scenario because we don't touch patients anything above 250 here.
No, 350 is the normal as per the American.
No, it depends on what kind of setup you're working in. If you're working in a hospital setup, I think the values are definitely different than working in a general practice.
No, even we do surgical bony and never, the patient never comes back, because 350 is ideal, because as you told, like the patient for 20 years, his diabetic level, and you never expect the patient 272 less than to come below 270 or 280. Even if he is fasting for maybe 1 year, his diabetic level will never come down, because now he is dependent for the diabetic level, the glucose which has to be taken into the muscle, it is dependent on the drugs now. The body is no more getting activated. So that is the major issue. So for that reason, considering the recently 2017 American Diabetic Association protocol, it's anything above 350, any minor surgeries can be done. And if you want to go for a major surgery, then 350 is definitely a contraindication.
Just a small query again to Dr. Nida. You're a consultant. You consult different clinics for surgeries. What is your take on Dr. Siraj's point? Yeah, he said 350 is fair enough, but as a clinician, I think you have avoided anything above 250 also, if I'm not wrong. And I don't touch patients above 250. Please, your take. I'm talking about clinical Indian scenario, private clinic setup.
Yes, sir. Actually, when I also practice, it's 250, which I've considered. Anything above 250, even for a normal extraction, we don't go ahead with, because we feel that, the healing would be, hampered. So 250 is what the baseline is kept. But sir has told that in 2017, they've come up with new guidelines, which says 350. So I would like to look into it. But in the normal consultant where I go and the clinic setup, it is 250 only what I consider.
There's always been a never-ending debate when it comes to the cutoff of the RBS for the surgery. Because I think I never used to touch any patient anywhere above more than 200. You're talking about 250. I would always send the patient back if more than 200. I always considered, 200 was a fair enough cutoff. And now I think it's changing. Well, let us get into the details and the evidence based on that. The next question we would like to take from Dr. Iftikhar. What he wants to ask is, if a submucosal route, which one to be used, dexamethasone acetate or phosphate?
Both can be used.
Okay, short and sweet, huh? Both can be used.
Because acetate is the submucosal and intramuscular. The phosphate, acetate is mucosal and muscular. Both are safe, but not IV. Acetate should never be given IV.
IV, yes. The next question is from Dr. Fayaz. He says the upper level is for dental surgeries advised by endocrinologist to me, and he goes on to continue to be on a safer side. What's your opinion on this? I think he's already answered that the latest literature and says you can go up to 350. I think we request Dr. Siraj to post the evidence in the group, inshallah.
Yes, sir.
Okay, and then Dr. Fayaz again says, Dr. Nida Ahmed, thank you for excellent presentation and connecting the basic science behind practical clinical decision making. And he goes on to thank us as well. And are there any further questions from the participants, or can we call it a day? I would like to call in the host, Dr. Ali.
Thank you very much, Dr. Ahmed, Dr. Hassan, and Dr. Firdaus. It was brilliant. I would say, I think one of the most intriguing and interactive sessions I've ever come across so far, and it's enlightened me a lot on surgery, which used to be one of my favorite subjects, but I think I'm reviving the passion back. I would like all the participants to put their questions forward in the group, and if you have any queries, we're more than happy to take it in the group.
If I can just request you to extend the session for another 5 to 7 minutes, since we're talking about steroids, what's your experience on use of steroids in endodontics?
I don't use steroids in endodontics. Never used them.
Because there's a lot of literature which says steroids as an intracanal medicament, it's preferred. I don't know how far it's true.
The only intra-appointment intracanal medicament which has been used religiously is non-setting calcium hydroxide. No steroids, nothing, because the moment you're actually trying to reduce the strain of bacteria within the canal, and the best thing which works is calcium hydroxide. Steroid is an anti-inflammatory. And when the moment you remove the inflamed tissue from the canal, you place the calcium hydroxide, that does the job. You give 2 weeks and then review the patient and then rechange the dressing as the swelling and everything goes down. But usually the signs are seen after 48 hours to 72 hours. Patient feels a lot better. There's no need for...
Yeah, please. Because I had come across a couple of literature which says, the application of the steroids intracanal, it reduces the pulpal inflammation, also helps in the root resorption process. Is that true?
I don't think so. If you're dealing with conventional root canal therapy, there's no use of steroids. Even if you're trying to do vital pulp therapy, again, I think the first talk which I posted, unfortunately it wasn't recorded, but I said a few things about vital pulp therapy as well. But there's no need for steroids because you have the biomaterials which are far more superior in healing the pulp. And we should also remember the pulp has stem cells which can repair itself and relay reparative dentine. So, and that, that basic property of, I would call it an organ, the dentine pulp organ, to heal itself, advocates no use of steroids. I haven't come across any substantial evidence for it. But I'm happy if you could share that on the group. We could have a more detailed discussion about it.
I think I'll put it across. It also says it helps in the reduction of the post-thermal sensitivity if you use it as a sealer. I don't know what exactly they mean by that.
Basically, you see, if you remember, I don't know if you guys use odonto paste or Ledamix in Saudi Arabia or in India.
Yeah, Ledamix, yeah.
So Ledamix is a mixture of doxycycline, a steroid, and I think one other drug. I don't know the name. So this used to be provided for emergency. If a patient walks into the office saying that, yeah, I'm in severe pain and I just need to, get me out of pain and then I'll come back for treatment, and you don't have the time slots, what the dentists generally do is use this paste. They place it on top of the pulp tissue, inflamed pulp tissue. Technically, I personally don't use it, and I would not advocate the use of it because you open the access, you can extirpate it in, let's say, about 5 minutes. Once you've done it, you dry the canal and put calcium hydroxide. It does the same job. Yeah, okay. It does the same job, and it reduces all the inflammation you need. So odonto paste is another thing that contains clindamycin. It's an antibacterial steroid and an anti-inflammatory mix paste. But there's no need for all these things in endodontics. You can keep it simple. Just use non-setting calcium hydroxide. It does the same job. The more you see, in endodontics, the scenario is the bacteria inside the canal. And if at all there is some inflamed tissue left inside, these are the ones which cause the pain. So if you get rid of these, you're removing the inflamed tissue. You're cleaning the canal with hypochlorite, which reduces the strain of bacteria, or in fact, 99% of the time, it kills the bacteria. You dry the canal, then you have a clean field, and you place calcium hydroxide, which helps over a period of time to further reduce or make the environment non-conducive for recultivation of bacteria. That thereby helps the host response, to healing. So you don't need putting in steroids there. I hope that's clear.
Yeah, it's very clear. I think the steroid has multiple uses in terms of dentistry. Just to, I think, close the session, I would like to ask the effects of the steroids in orthodontics. If we can have the orthodontist on the panel, please. Dr. Basha Bhai?
I reckon Basha Bhai is, I'll just unmute him just a moment.
I just want to know the effects of orthodontics in case there are any effects in patients with steroids in terms of the orthodontic tooth movement? Since we're talking about steroids, I think I would like to involve all the other interdepartmental professionals as well, so that we can have a broader perspective of how steroids interact with dentistry.
The tooth movement is usually delayed whenever the steroids are taken. So usually we wait for the steroid therapy to be stopped to go ahead with the ortho treatment, or there's something called drug holiday period will be there. That time we do the minor tooth movement, whatever we have to do.
Thank you very much, Basha Bhai, for this for enlightenment of our steroids, and thank you so much, Dr. Nida. And I would really thank Dr. Shiraz to have chaired the panel out of his busy schedule. And also, I would like to thank all the participants who were actively participating in the session with their mind-blowing questions.
We have one, I think, Abid, endodontist.
His question was answered, whether the use of dexamethasone for syncope.
I think he's raised his hand. I don't know why he's raised his hand. Let's ask him. Dr. Abid?
Maybe he wants to ask Dr. Ali a question regarding the steroid.
Please, please. Sorry, Abid, I can't hear him. I think he's... I think we've lost him. Anyway, has he put the question forward to any one of you?
His question was, can we use dexamethasone to patient having syncope to revive him?
That's Dr. Hassan's
answer.
He's already answered, I reckon.
We've already answered that.
And I think Nadeem has raised his hand as well. If you don't mind, let's just finish.
Please.
No, yeah, I think Mubarak, I think you have already answered. I just wanted to say that I think what Dr. Firdaus was trying to point out in endo, use of steroids in endo. There's one article mentioned in JOE regarding the use of endodontic steroids in endodontics. It's an old article. Probably if I get a hand on it, I will post it on GDB.
Yeah, please do. We could comparatively study what exactly it benefits in endodontics, the use of steroids.
Yeah, right. Thank you.
Thanks. Well, thank you very much.
Yeah.
So Dr. Firdaus, you need to say
No, I think we are back to you. I think you can call it a day.
Brilliant. Thank you, everyone. Jazakallah khair. I think I'll end this meeting so that we could continue it in the group. Had a wonderful interactive session with all of you. Thank you and hope you have a nice weekend. Thank you very much.
Thank you so much. Thank you, everybody.
Allah Hafiz.
Thank you.
Allah Hafiz.